sessions, but actually for a couple of the speakers, including our next speaker, Dr. Amy Geddis, she has to be at her sister's wedding this weekend.
My nephew's wedding.
Oh, your nephew's wedding. So,
the next generation.
So, but having said that, it's a great pleasure to have Dr. Geddis here today. Amy has actually become my go-to person for any issues with platelets and Paris-Trousseau syndrome. So Amy is an MD and a Ph.D. pediatric hematology oncology doctor whose specific area of interest is in platelets. And so she has graciously had an interest in helping work with us to try to understand what Paris-Trousseau is and what the clinical implications are for your children. To this day, there's still, I think, a lot of confusion about what exactly is the platelet problem in children with Jacobsen syndrome. And I can tell you a profound example just about from an hour ago when a mom came up to me and told me that she took her daughter to Children's Hospital of Philadelphia and had an extensive workup and was ultimately told that her child does not have Paris-Trousseau syndrome, despite the fact that she was born with a low platelet count. So I said, your kid has Paris-Trousseau syndrome. I think the confusion arises in the semantics, and so it's great to have Amy here today, who I think is going to help us to better define what Paris-Trousseau syndrome is, and most importantly, what the implications are of that for your children. I should also point out that Amy was instrumental in helping us to come up with the bleeding protocol that hopefully all of you are aware of, along with Chuck Haymeyer, who you're going to be hearing from Saturday morning. You'll hear a lot more about medical protocols at that time. So, Amy, I have a couple of little things for you.
Okay.
There's also a T-shirt that's got your name on it for later on today. We haven't arrived yet. But thank you again so much for coming.
Oh, thank you.
Put this over here.
All right, can everybody hear me? I don't know if this is it. Okay. So I want to talk a little bit about bleeding in Paris-Trousseau syndrome, because I think it's something that causes a lot of anxiety and, again, like Paul said, a lot of confusion. And this talk doesn't take anywhere near the whole hour, so there's plenty of time for questions at the end. Okay. So a lot of this is information you already know, but Paris-Trousseau syndrome is basically defined as an inherited disorder, and the children it's a syndrome, so they have to have a constellation of features which tend to include heart defects, some types of neurologic impairment, a delay in growth and development, and importantly for this talk, also low platelets. And as you know, it can be genetically defined now as a deletion involving the terminal portion of chromosome 11q. And just a few, following the last talk, this is unnecessary, but just why these chromosomal deletions matter. As you know, you have 2 copies of every gene that's in the body normally. One comes from each parent. But if one copy is lost, sometimes it doesn't make any difference, but sometimes there may not be enough of that protein product for whatever that gene encodes for the cell to function normally. And even if there is enough protein product for that cell to function normally, that cell is now very susceptible to any changes or mutations that happens in the remaining gene copy. And so a deleted region of the chromosome can be small or large and contains many genes, and the number of genes that are deleted in any one person often defines the phenotype or what that person looks like. So this is the gene that's deleted on the terminal portion of 11q that most people agree is probably the most important in causing the platelet problem in Paris-Trousseau syndrome. It's called FLI1. FLI1 is typically lost in the deleted portion of chromosome 11q, and it's known in many, many experiments through mice and manipulated cells, as well as in this disorder, to be essential for megakaryocyte and platelet development. And you can see in this chart here, FLI1 promotes platelet development and also inhibits red cells. So along when the cells are differentiating from the stem cell, which can turn into any kind of cell, it's subject to the influences of many genes along the way, which help determine whether that stem cell grows up to be a red cell, a platelet, or a white blood cell. And in particular, the influence of FLI1 is very important to direct those cells to turn into megakaryocytes and platelets. So without FLI1, the cell would be more encouraged to turn into a red blood cell than a platelet at the critical time of action of that protein. So megakaryocytes, you probably hear about them. Megakaryocytes are large cells in the bone marrow. That's why they're called megakaryocytes. and they're the cells that are responsible for making your platelets. So each megakaryocyte can make up to 150 billion platelets, up to 1,000 platelets for every person to produce 150 billion platelets every day, and that's just to maintain your normal homeostatic state. This should be a movie, but unfortunately I realized I did not put the movie file on the zip disk, but it shows the megakaryocyte. You can see the start here at the right-hand side. It shows the megakaryocyte basically dissolving into these thousands of platelets that it's going to make in the bone marrow, which will then enter the blood and circulate in the body. Platelets are very small cells. They don't have nuclei, and they're packed with little granules, and these granules are called alpha granules and dense granules, and they contain different substances, and these packages are kind of poised to release when the platelet is activated, and the release of these granules encourage the platelets to activate other platelets, to stick to the blood vessel wall, to activate the clotting system, and these granules are then very important in terms of how well the platelets actually function. So you have two different parts of the equation. You have to have adequate numbers of platelets, and then those platelets have to have normal granules that help the platelets to function normally. So have a number and function, two different pieces of the puzzle. And in the lab, there's a number of ways of testing platelet function, and one of them is by treating the platelets in a test tube environment with different agents that will stimulate the release of different granules, and you can test the platelets in that way to see if they're normally functional. And these are called platelet aggregation studies. So how are platelets in Paris-Trousseau syndrome different? Well, we know that starting off at birth, people typically often do not have enough platelets, so they have low numbers of platelets. But we also think that the platelets are not normally functional, and part of this abnormal function probably comes with the fact that the granules in the platelets of Paris-Trousseau syndrome are different. In particular, the alpha granules tend to aggregate and form this big glob in a Paris-Trousseau syndrome platelet. So you can see the normal platelet, they have little granules. You can see them kind of on the periphery of the cell. They're well spaced apart, and they're small, they're individual. In the Paris-Trousseau syndrome platelet, you have this big dense granule right in the middle. And so you can see that the architecture of those two platelets is different, so it's not that hard to imagine that the function of those two platelets would also be different. It's also been shown that the dense granules of the platelets, which have a different function than the alpha granules in Paris-Trousseau syndrome, are not as frequent or reduced in number compared to normal platelets. And so again, both granules seem to be different in these platelets, hence the function of the platelets is probably also different. So as Paul alluded to, the platelet function question in Paris-Trousseau syndrome is not well defined. This could be for a number of reasons. One, it's a relatively uncommon disorder, so it's hard to get enough patients together to say that these people are the same and let's study their platelets. Platelet testing can be very difficult to do in people who don't have adequate numbers of platelets, because most of our available platelet tests is hard to separate the fact that that the platelet function is low because there's just not enough platelets, to the question of whether the function of the individual platelet is abnormal. So those are difficult to separate in the labs. So if you have somebody who has low numbers of platelets, it's very hard to ask the question, do those platelets function normally or not? And then what we do know is that in people with Paris-Trousseau syndrome that do seem to have adequate numbers of platelets, so that's more than 100,000 platelets, the bleeding times tend to be prolonged. So that would suggest that there's something additional to just low platelet numbers that is contributing to bleeding in those patients. In addition, people in the laboratory have studied individual platelets with these fused alpha granules and shown that they activate in response to different chemicals slower or not at all compared to normal platelets. So again, suggesting that these abnormal granules in these platelets are not functioning normally. And again, we know that there are specific disorders associated with people that have low numbers of dense granules, and Paris-Trousseau platelets tend to have low number of dense granules, so you would infer that the function of those platelets, again, would be different. So what are the symptoms of low platelets or low platelet function? When you have low platelets, the type of bleeding people often experience is something we call mucous membrane bleeding. And this tends, the mucous membranes we tend to refer to are like the lining of the nose, the lining of the mouth, the gums, the GI tract. Those are all mucous membranes. And platelets are very important in controlling bleeding symptoms in those areas. Bruising and petechiae is also a very common symptom when you have low platelets. Bruising, or obviously everybody knows what bruises are, but petechiae are those little tiny bruises that look like freckles, like little purple freckles, and those happen when your platelets are especially low. Usually if people's platelets are less than 20,000, they might experience petechiae. So bruising, petechiae, especially if a child is crying, or sometimes you'll notice after a bout of crying, they'll get a little petechiae around their eyes. Gum bleeding or oozing after dental extraction. So if you've had a tooth pulled and it just seemed to ooze a lot longer than you expected, that's sort of a classic symptom of low platelet number or low platelet function. Nosebleeds are very common, especially in San Diego where it's dry, but we get it particularly piques our interest that the bleeding may be abnormal if the nosebleeds persistently last longer than 20 minutes. If they've ever been so long and had a nosebleed that's so much that you actually required a blood transfusion, then these are obviously abnormal. Sometimes people have frequent small nosebleeds, and it's harder to determine whether that's really normal or abnormal because in some areas of the country it's so common. Menstrual bleeding in women and teenagers, that's also common in people with low platelets or low platelet function. They have prolonged menstrual bleeds that are heavy, again, sometimes to the point where girls develop iron deficiency. And again, when you have a lot of these types of symptoms, but your platelet count is relatively good, more than 50,000, more than 100,000, then it suggests that there's some component of platelet dysfunction as well as just a low platelet number. Because most people, if they have a platelet count more than 50 and their platelets function normally, do not really have that many symptoms. So how do you test for platelet dysfunction? Well, as I said before, it can be tricky to separate the question of low platelet numbers to low platelet function. Most of these tests are better done are easier to interpret if the platelet count is more than 100,000. So probably the oldest and the most intuitive test is the bleeding time. This basically means you just make a cut on somebody's arm. But it's not just any cut, it's a very specific cut. It has to be in a certain direction, it has to be a certain length, it has to be a certain depth, very standardized cut on somebody's arm, and then you measure the time that it takes for that cut to stop bleeding. So the nice thing about this test is it's sort of a real time, it's like a real life test. I mean, you're not testing something in a test tube, you're actually testing how somebody stops bleeding, and it involves the tissues and all the factors in the blood and the platelets all together in sort of a real environment. The hard part about this test is that it's really difficult to be very reproducible, especially if you have a child that you're trying to do it on and they're not really happy about having a cut on their arm, so they're going to be screaming and thrashing around, and to make that defined cut of exactly the right depth and length is going to be really tricky. And it's kind of been abandoned just because there are so many variabilities to getting this test performed in a really standardized way. And like any other test of platelet function, if you have low platelet numbers, the test will be prolonged, so it's difficult to interpret in that setting. If you've also, with any of these tests, if you've taken aspirin or medications that we know affect platelet function, the test will be abnormal. So it has to be done in somebody with close to normal numbers of platelets, more than 100,000, and not on aspirin or other medications that can affect the test. The test that somewhat replaced the bleeding time is called the PFA 100. The PFA stands for Platelet Function Assay. Instead of making a cut on somebody's arm, in this setting you run the blood through a little cartridge with a tiny pinhole in it, and you measure how long it takes for the platelets to occlude that little pinhole, to clot off that little pinhole. It's more reproducible than the bleeding time since the cartridge can be made standardly. It doesn't rely on making a cut in somebody's arm. But even though it's called a platelet function assay, it's relatively insensitive to many types of platelet function. It really is most sensitive to detecting whether somebody's taking aspirin or not. And they use it a lot in cardiology clinics to determine if the patients that are taking aspirin, who need to be taking them for the fact that they have a stent or something that they want them to be aspirin on, they use the PFA, I think, frequently to determine whether they're getting therapeutic doses of aspirin or not. It's very good for that. But just because you have a normal PFA 100 doesn't rule out that you may have dysfunctional platelets. It just doesn't test for that many different types of platelet function. Platelet aggregation testing is probably the best test that we have for platelet function, the most comprehensive. In this setting, you take platelets and you treat them with different chemicals, and the chemicals will stimulate the platelets to release their granules and stick together. And when the platelets stick together, when you shine light through the suspension of platelets and they stick together, the light will be able to pass through more easily because there's going to be space around those little clumps of platelets. And so the testing basically will measure how long it takes for the platelets to start sticking together in response to the different chemicals that you treat them with. So it tests different pathways that should stimulate the platelets to release their granules and stick together. The nice advantage of this test is that you can test several different types of pathways, so you can get at different aspects of platelet function. Some patients have very specific defects in platelet function, and they'll be normal in response to some chemicals, but abnormal in response to others. And so in that setting, I think it's a lot more sensitive. Couple of problems. We know that in our body, platelets aren't just sort of sitting in a solution waiting to stick to each other. They're actually flowing in the blood, and we think that a lot of that blood flow causes some shear, and that's actually part of what makes the platelets function. They actually function in an environment where there's kind of a fluid shear flow going on, as opposed to just sort of sitting in a solution not doing anything. So it doesn't really mimic what's going on in the body precisely. So again, it doesn't test things as they are actually going on in the body. The other problem with this test, like any other test, like any of the other platelet tests, is hard to perform in patients with low numbers of platelets. You have to have at least 100,000 platelets to perform this test, and it takes a fair amount of blood, 10 to 20 mLs of blood to perform this assay, so not appropriate for very small children. So different tests, they all have their advantages and disadvantages, and it's just important to interpret the information that you get from them in light of the fact that none of these are perfect assays. So what's the natural history of low platelets in Paris-Trousseau syndrome? Again, as Paul alluded to, the thrombocytopenia is most commonly a problem at birth. So at birth, the platelets might be very low, less than 10 or 20,000 per microliter. And this is, just for reference, a normal platelet count in a baby is more than 150,000. Actually, normal platelet count in anybody is more than 150,000. We know that even though platelets of 10 to 20 are low enough that children often may have spontaneous issues with bleeding, typically when the platelets are more than 50,000, that pretty much resolves the spontaneous issues with bleeding. And so even though the platelets aren't normal, most of the bleeding issues usually go away when the platelets start to be in that more than 50,000 range. And in fact, with time, most children with Paris-Trousseau syndrome, even if they start out with very low platelets, do tend to improve their platelet counts into that range where they don't have so many spontaneous issues, and maybe even into the normal range, or at least more than 100,000, which most people feel is relatively safe platelet count if you're not having surgeries in terms of risk of bleeding. But as we said before, even though the platelet count number increases, this issue of the platelet function may persist, and exactly how much platelet dysfunction there is probably varies from patient to patient and is not very well defined. So how do we manage platelet bleeding symptoms? So there's a couple of tools we have to try to improve or reduce bleeding symptoms in people with platelet problems. And none of these are specific to people with Paris-Trousseau syndrome. These are things we do for anybody with platelet function or platelet number problems. So the first medication that can sometimes be helpful is a medicine called Amicar. There's another medicine that's similar to this, but just for this purposes, I'll talk about Amicar. This medicine can be used as a mouthwash. It's a liquid that you can swish and spit. It can be given as a pill, a liquid that you take by mouth that you ingest, or a pill that you ingest, so several different forms. Even comes as an IV form that can be used in the clinic or in the operating room. This medicine works by, it doesn't help the platelets to form a clot, but once there is a clot, it helps stabilize that clot so it doesn't break down as fast. And it's particularly useful in the mouth for bleeding that's located in the mouth. So we use it most commonly after dental procedures. So you need to have a tooth pulled, and we're worried that you may have bleeding or oozing after the tooth is pulled, and we can prescribe Amicar following the tooth extraction. And typically, once that little clot in your tooth socket is formed, the Amicar will help keep it stable until the healing has taken place, and then you can stop taking the Amicar. Small children, the other type of mouth injury that this is kind of useful for is when they either they bite their tongue or injure their frenulum. Those things can bleed a lot and for a long period of time. Amicar can be very useful in helping to control those types of bleeds until they have a time to heal. And in girls, occasionally we use Amicar for help with heavy periods. Oral contraceptives, speaking of girls, can be very helpful for girls who have problems with prolonged or heavy menses. These can work, but these can be taken either in the traditional way where you have a bleed every month, or they can be taken in the more new way where you have a bleed maybe 4 times a year. So you take the pill for 3 months at a time and then have a withdrawal bleed 4 times a year. And this can be when the withdrawal bleeds do happen, they tend to be lighter and much easier to control. So this medicine can be very helpful for people with heavy periods due to bleeding disorders. DDAVP is the next medicine. It's helpful for people with platelet dysfunction, although we don't always know exactly how it works. It can be used either IV, so it can be given in the clinic or the operating room prior to a procedure, or it can be given as a nasal spray, so something you could have at home to help with bleeding symptoms. The important thing about DDAVP is you can't use it on a daily basis. You can only use it for 2 or 3 days in a row. After that, it tends to lose its effect. Also, when you use DDAVP, it's important to limit how much fluids you drink because it can you can retain free water, and then when you're on DDAVP. So usually for 24 hours after the medication, we recommend that you reduce your fluid intake. And the last way we can manage bleeding issues for people with low platelet numbers or low platelet function is by giving a platelet transfusion. Usually this is reserved for serious bleeding or before major surgeries, just because there are certain risks to any blood transfusion, so we try to reserve it for more serious bleeding issues and not minor bleeding issues. Minor bleeding issues we try to handle with these other methods. So when would you consider transfusing platelets? Well, certainly if your platelet number is very low, then these other issues, they may help, but if your platelet number is very low in that 10 to 20,000 range, then really the best way to approach the problem is to give platelets. If there's significant bleeding or bleeding you've already tried the other things and it's not working, then it'd be a good reason to give platelets. If there's surgery, a dental extraction or invasive procedure where the surgeon says, I want the platelets to be more than 50,000, so then even if your platelets are 30 or 40, often the goal for a more invasive procedure is platelets that are at least 50,000. Or any high-risk procedure where any amount of bleeding would just be very risky. So if you have some procedures where the risk of bleeding is high and the consequences of having uncontrolled bleeding would be significant, then you would want to err on the side of safety and give platelets. Or a major trauma, for example, if there's a head injury, you would want to make sure, again, another situation where you're not going to sort of go from strategy 1 to 2 to 3, you're just going to go right for the platelets because, again, you want to make sure that any bleeding is treated right away. And again, the reasons why we try to avoid platelets, and we don't give them all the time, and we try to limit them to these types of situations, are because some people can have allergic reactions to platelet proteins. Some people, if you transfuse them over and over again, they start to becoming less responsive to platelets, and so we want to make sure if we think that they may need them in the future, we kind of maintain their responsiveness for that possibility. And then, of course, they can, any blood product can be a vector to transmit infections, both viral infections as well as bacterial infections. Platelets themselves are somewhat prone, platelet transfusions themselves are somewhat prone to bacterial infection because they can't be stored in the cold. They can only be stored at room temperature. So if there is any bacterial contamination of the platelets during the donation process, those bacteria can grow in the setting where the platelets are being stored at room temperature. So it doesn't happen very often, but it can happen. And again, one reason to just make sure that you have a good reason to give platelets when you're giving them.
In relation to the bacteria possibility, the transmission, most recently my daughter had a staph infection and they used irradiated platelets, which they described as an extra protection because of that.
So radiation doesn't necessarily prevent bacterial infection. It does prevent certain viral infections by killing the white blood cells that may harbor viruses. Most platelet donation these days are collected in a way that removes most of the white blood cells, so it's not. So most of them, those types of viruses are removed. Radiation is most helpful for. We use it in patients with whose immune system does not function normally to prevent the white cells from actually engrafting. It causes something called transfusion-associated graft-versus-host disease. But you can still have it. It's not a fail-safe for bacterial to prevent bacterial infections.
So if you're in a situation where you're having a bad infection, should we, like, push for it to be that way for extra protection, or is it not really relevant?
Yeah, I think if you already have the infection, treating the platelets is not going to change. It's not going to change anything. Treating the platelets you're getting. The blood bank has a number of precautions in place to try to reduce the chances of bacterial infection in the platelets. You can't give the platelet. The platelets have to be stored a couple of days to prove that at least in that period of time before they're used, to prove that at least in that period of time there hasn't been any evidence of an infection. And the platelets have to be used before 4 or 5 days, so that there's a very small window in which you can actually use the platelets because of that concern. So they have some safeguards in place to try to limit the possibility that there would be an infection. Okay. But of course, as you know, that our understanding of exactly what's causing the platelet dysfunction in Paris-Trousseau patients is not very clear. And I'm a cat person, so my cat would be napping for sure. But one proposed project that I thought would be appropriate for this group, just because this is a rare opportunity to have a larger number of families interested in this problem that periodically every 2 years are in the same place, would be to try to ask the question, is there a common abnormality of platelet function in patients with Paris-Trousseau syndrome? So if we looked at 10 people or 20 people, would we see basically the same thing, or would they all have something different? I think we don't know that question. And if we did a standard assay in those 10 or 20 people, would it correlate with the type of bleeding that patient experienced, or is it completely random? Do some people have normal looking testing and then they don't tend to bleed, or they do bleed a lot, and other people have abnormal looking testing and they don't tend to bleed? If there's not a relationship, then there's no real point doing the testing, because it doesn't help you decide how you need to manage that person when they go for a surgery or anything. But if there is a correlation, then maybe you could decide this person needs platelets before surgery, this person doesn't, because based on this testing I could predict. So I think those are things that we don't really know. And the question would be if you could get as many as 10 or 20 people who had enough platelets, a high enough platelet count that you could assess their function, so more than 100,000, big enough to donate a blood sample, and not getting aspirin or something that would make it difficult to look at platelet function, would you be able to answer these two questions? And it was something that I considered doing at this meeting, but then because my nephew was getting married, that wasn't going to work because I'm not going to be here. But it might be something that would be worthwhile for a future meeting if enough people are interested. And again, would involve a blood draw, as well as a bleeding questionnaire, again, to try to correlate what you might find on the platelet function testing to those person's bleeding symptoms. Asking questions about how much do you bruise, how often do you have nosebleeds, how long are those nosebleeds. For girls, are there problems with their periods? If they've had surgeries or dental extractions, did they seem to have abnormal bleeding? Did they need extra intervention, either a platelet transfusion or some other means to get them to stop? And then the platelet test, function test, which would take about 2 to 4 teaspoons of blood to perform. So that would be a proposed project to consider for the next meeting if people are interested. Probably be sending around, I think I sent around like a letter of interest last time to try to gauge if there would be enough people to do, who are interested to make it worth doing this study. And I would also probably, if I was planning to do it, send out consents in the mail ahead of time so that when you came it would be ready to go. And that's it. If there's any questions, we have lots of time. Platelets or platelet function, yeah.
What are any long-term, I know you said that the more transfusions you have, the less likely the platelet, the less likely they'll work in the future. Are there any other long-term effects of a lot of platelet
transfusion? So the possibility, if you're getting frequent, there is a possibility if you're getting frequent platelet transfusion that you stop reacting to them. If they're infrequent transfusions, that's probably less likely to happen, but just something to bear in mind. Occasionally people can develop more specific antibodies against the platelet products so that subsequent transfusions don't work at all. Infections, probably the biggest long-term consequence that we get concerned about. I think with any blood transfusion, there is an unanswered question about whether there's some change in the immune system. There's a lot of people sort of looking at that question. I think it's something that there's not a lot of data on to say one way or another. If there is, but there's a concern that maybe when you transfuse somebody with anything, either blood or platelets, that you alter the way the immune system acts, at least temporarily, in response to that transfusion. So again, typically I think when we do use a transfusion of any type, we want to feel relatively certain that the risks and benefits equation that we really need to use that transfusion. Yep.
Would be a number to be cause for concern for being, too many? I mean, like after 12 in a certain amount of time.
Oh, you mean too many transfusions?
Yeah.
We see these we see this problem most frequently in our patients that are hospitalized. It would be most likely, I would think, happen if it was going to be an issue. It'd be something that happens when the platelets are very low in somebody who's in the hospital and then receiving platelets for multiple days, like on a daily, every other day basis for several weeks, something like that. So not typically an issue that people are going to run into if they're getting infrequent transfusions. It's most often something we see in the hospitalized setting.
So is it, if you've got the Paris-Trousseau, is it possible that it doesn't actually show its face?
That there's not a problem with the platelets?
Yeah.
Can you repeat the question?
She wants to know if all people with Paris-Trousseau have low platelets, or if is it possible to have Paris-Trousseau and to have normal platelet numbers.
Well, like my daughter's 3.5 and she's got the platelet dysfunction, but she's never shown any signs of a problem with it yet.
She never, yeah. So, and children, that's very common because again, we don't know if everybody has the same degree of platelet dysfunction, and in children sometimes they haven't really had a challenge. So it depends what kind of surgeries or what kind of things you run up against. So she's had surgeries.
Surgeries yet, and her bleeding was fine. She didn't need any extra.
That's good. That's great. Yeah, so I think that's a question we don't know is again what the degree of variation is in terms of how many people have that, because I know there's some people that have a lot of problems with bleeding and other people that don't. I don't think we know why that is.
Do the symptoms develop as the child gets older? Because when Demi was quite young, we didn't know had many problems. Yes, the odds if she cut herself, it did seem to be longer, but we didn't know at the time. But as she's got older, she's had nosebleeds and obviously the hemiplegias, but a lot of nosebleeds, and they came out of nowhere, to be honest. But she didn't have them when she was younger. So is it possible it could develop further as she gets older or not?
I don't think the platelet function changes so much as the stages of people's lives change. So children change as they get older, and when they're younger, they're not doing as many things. When they get older, I think they get more active. The nosebleeds, I think, most of the children that we see have nosebleeds. It tends to be worse in that school age time, and I don't know if it's because of the number of colds and infections they're having that irritate the nose and make it a setup for nosebleeds. If that's the age, they're also sometimes scratching in their nose or other things.
Or stress seems to set.
Yeah. So a lot of people that we see, they have bad nosebleeds when they're in that young age group where they're having a lot of colds, infections, allergies, those kinds of symptoms, and then when they get older, they tend to get better. So I hear that story all the time with people with different, not just Paris-Trousseau, but other things where that's the age that they tend to have nosebleeds and they tend to grow out of their nosebleeds. I think it's more that they change than their platelets change. And then when they get to be teenagers, it'll be more whether they're having issues with their periods.
No, she started developing the nosebleeds in the teenage years.
Oh really? Okay.
So there's nothing when she was younger.
Yeah. I don't think the platelets change so much. I think it's more the environment and the people that change. I mean, the stage in your life, and the other things that are going on with you change.
With the scheduled tooth extractions, several tooth extractions coming up, is Amicar a good thing to go on prophylactically before, or is it just after?
It tends to be after, because the job of Amicar is to stabilize the clot. So once the clot's formed, then you use the Amicar. So we tend to do it after. And so it's something that it can, if it's a tooth in the front, you could use it as the swish and spit. Sometimes that's more popular than the swallow version. So you could use that, or have it on hand. It tends to be, I would definitely check ahead of time, because not every pharmacy covers it, and it's quite pricey. So you want to make sure your insurance covers it.
How do you, if you said a lot of those testings are really inconclusive, if you don't have like 100,000 or more, what if they're always like right there and they've had all these testings, and you know, sometimes bleeding is worse than other times without any real reason why? And I don't remember the name of another test that my daughter's doctor did to check other factors associated with bleeding, and
things like von Willebrand's, or
so it was okay. And you know, but if you're never over 100, I mean, I think 110 is probably fantastic.
Yeah.
So how would you know about being conclusive about what's really going on with the functionality?
So sometimes that's why we end up treating people. We end up assuming if we can't test, then we know that there's a possibility that there's platelet dysfunction, and you just assume that there's some dysfunction there, and you are prepared to treat bleeding. So in somebody with a different platelet problem, when you get their platelets up to 100, if you assume that they function normally, you think that's going to be enough. In this setting, it's like, well, it may be enough, but if the platelets aren't functioning normally, I may need to do other thing else. So you just need to have a bleeding plan and assume that there might be some dysfunction. So typically I think that sometimes you can't answer the question. The platelets are too low, the child's too small, the tests aren't conclusive, they're on aspirin and you can't take them off the aspirin, so you can't answer the question. And then I think you just assume that there's dysfunction, and you say, okay, the platelets are 100, it should be okay for this procedure, but in the event that they're not working normally, there might be some problems, so I need to plan so that if there's more bleeding than I expect, what I'll do about it. So it's really all about just being prepared for the possibility of bleeding, and knowing what you would do if there was a bleeding problem.
If I could just add to that, I think that's a really important point, which is why we have this protocol. So if you're ever faced in a potentially life-threatening bleeding situation for your child, bring that protocol, and again, we'll talk about this more on Saturday, and you tell whoever the treating physician is, my child has Paris-Trousseau syndrome, here's what you do. And don't let them get into a debate about, they're probably not going to be savvy enough anyway to know. But I think until we can do these more sophisticated studies, hopefully at the next conference, we should assume that all of your children have Paris-Trousseau until proven otherwise. I think that's the safest.
Yeah. And doesn't mean you necessarily need to give platelets, but you say, well, if they have bleeding and it's not being controlled, then that's that will solve the issue if the bleeding is due to platelet dysfunction. So at least you know that what you would do if that was the problem. So even if you don't do something preventatively, you know how you have a plan how you manage bleeding in the event that it wasn't responding to those measures.
Daily life, when you have to have concerns about, we were talking about people who are on aspirin. Well, I thought if you had low platelets, especially ones that stay under 100, you shouldn't have that. Or what about the things like, what is it, Alka-Seltzer, Rolaids, and all that kind of stuff?
So,
and garlic and
yeah, so you're right. So the garlic and fish oil, there's a whole list of things that can sort of increase your tendency to bleed, which if you have low platelets, you should avoid. So aspirin, ibuprofen, garlic, fish oils, all those things can increase your tendency to bleed even at a normal platelet count. The question of what number you use aspirin at is sort of an ongoing conversation with the cardiologist because it depends what they need the aspirin for, and if your platelets are 100, they may feel that that's high enough that they need the aspirin. So it's going to be an ongoing, that's a partnership. I don't think there's a specific number you can say that you can't have aspirin in that setting, because that's going to be partly what they're going to decide depending on what type of surgery they've had. What number do you typically use, Paul?
I don't know about
it. It varies.
I refer them to the hematologist.
Yeah.
So most of the time they're like, I mean, half of them don't even know not to take, Private and Rolaids and stuff like that. When I asked that question, like, oh, they're going to give her steroids, give her, the antacid. I was like, wait a minute, is that much she can take, or is that much she can? And they're like, huh? So it's like, I'm always trying to be cautious, because, if I only have a number of 97, I don't want to play. So, so you avoid it. So what do you do then when, how do you last?
As a cardiologist, it's a dilemma. I mean, if you have a child that has a cardiac condition where if they form clot in their cardiovascular system, it could be fatal. At the same time, you're weighing that risk against the risk of having a life-threatening breathing complication from whatever. So I think that just argues for why we've got to bring Dr. Geddis back 2 years from now to do this.
Yeah.
I think then we can individualize the
yeah, and it's hard to just go by the platelet number in some ways, because, for example, there's a common platelet disorder that we see called ITP, where people make antibodies against their platelets, and the remaining platelets typically tend to be very functional. So people usually have way less bleeding symptoms than you would expect, even at very low platelet counts. Sometimes people walking around with platelet counts of 2 and not a bruise on them. And those kids really are actually prone to clot. So you would treat them with aspirin in the setting of a cardiac reason for it at a lot lower numbers than you would somebody who has low platelets for another reason, especially if it might involve platelet dysfunction. The amount of unwanting bleeding you're going to have in those two situations is going to be very different. And so, yeah, sometimes it's hard to predict. So I think in that setting where your platelets are riding 100, it's a conversation with the cardiologist. How risky is it not to be on aspirin? And then you may have to sort of, if they feel that it's important that they're on aspirin and you figure you should try it, it could be one of these people that doesn't really have that many bleeding symptoms and they do fine on it, and then there could be somebody else that just doesn't tolerate it, and that gives you your answer too, that you can't do it. So you might have to, there may be some room for trial and error in those situations, because we don't have the tests that allow us to accurately predict.
And Paul, what about, in circumstances where you have like increased blood pressure, right? And then they're like kind of debating back and forth about what kind of medication they can have that'll have less risk on the platelets, but help control blood pressure.
Well,
I mean, like, how cautious do we need to be, or how concerned do I need to be about how long we take that kind of stuff?
Yeah, I mean, certainly people that have very high blood pressure are in general at risk for catastrophic bleeding problems like brain damage. So, for many reasons, we want to see if we can do everything we can to keep this high blood pressure under control. Were you asking whether or not any blood pressure medications?
Yeah, because there was a lot of it. Because he started having PVCs and really quick all of a sudden high blood pressure. So, everybody was kind of scrambling trying to figure out which to handle first. And then there was a big problem trying to decide on what kind of medication, what kind of blood pressure medication she could take because her platelet counts were low.
Because,
everybody's always kind of like worried about that. And
I'm not aware of a common categories?
Yeah, they're the typical ones. I mean, calcium, it might be the calcium. It might be that they're concerned about the calcium channel blockers, just because calcium is an important drug that, or important trigger of platelet function. So it could be that they were concerned about.
Yeah, because they were saying that she couldn't take a calcium supplement. Mm-hmm. So I mean, is that correct?
Well, in the cardiology world, in kids, we don't use calcium channel blockers very often because they can potentially compromise cardiac function. So I think, the classes that we use, diuretics, something called an ACE inhibitor, or a beta blocker, to my knowledge, I'm not aware of those affecting calcium function. So there actually are plenty of options.
Yeah, that's a good thing, is there's so many different classes that you should be able to find something to get around whatever your restriction is. But yeah, like Paul said, I think in high blood pressure in the setting of low platelets is something that you want to have under control.
I have a user online that's asking me to read list of the things that can interfere with platelets, like aspirin.
To relist them? Sorry. So what was the question?
To relist the things that can affect the platelets, like aspirin.
Yeah, so, can we have that run over, because a lot of parents aren't aware of it.
Aspirin, basically all the what we call non-steroidal anti-inflammatory medications, that includes Motrin, Advil, Naproxen, all the different names for Motrin, Advil, ibuprofen. They have a bunch of different trade names, but they're all the same types of medications. Sometimes I tell people it's easier to remember what they can't take, and so Tylenol is going to be for just generic treatment of headaches or pain or mild pain. Tylenol is going to be a safer choice as far as platelet function goes than any of those other medications. If you do have a specific inflammatory condition that you need that anti-inflammatory component of those medications, the Celebrex has minimal effects on platelets, and so in that setting, you could, if you had an inflamed joint and you needed the anti-inflammatory effect, you could use Celebrex as opposed to Motrin, and without having an effect on the platelets. But in general, just for headaches and fevers, we just say to remember to take Tylenol and not to take those other medications. It's important when you look at cold medications and over-the-counter supplements that are combinations of things, because often they already have some ibuprofen or something mixed into them. So it's important to read the label on those kind of preparations to make sure that they don't contain ibuprofen or related medication that would have effect on platelet function. And then Pepto-Bismol is one of the sleeper medications. It actually contains some aspirin, so you might not expect that Pepto-Bismol, there was anything wrong with it, but Pepto-Bismol has an aspirin-like medication in it, so you wouldn't want to take that medication. Those are ones we commonly tell people about. The supplements that people take, like fish oils, the reason why people take them in to prevent cardiovascular disease is because they make your platelets more slippery, and for people who are worried about coronary artery disease, that's a good thing. But if you take a lot of fish oils or excessive amounts of garlic, this isn't to mean that you can't have it on your pizza, but it's like, those mega doses, they can make your blood a little bit less clottable, which again is the effect that they're looking for in that setting, but you need to be aware if you already have a tendency to bleed that could bring it out. So we usually tell people to avoid those medications. The easiest thing to remember is if you have a supplement or something that you want to use, just ask your doctor if it's okay or not.
What are the problems? What is the issue with like the Rolaids and the Alka-Seltzers? What's the problem that's in there?
I mean, Rolaids is not really, I'm not aware of a problem. I never tell people not to take Rolaids. They don't affect platelet function. Alka-Seltzer, I don't believe has any aspirin in it. It's the Pepto-Bismol that has the aspirin in it. So
like the Platelets and stuff are okay?
Platelet should not really affect platelet function.
Yeah, this Tagamet was okay, they said.
Yeah.
So this Metadine was okay.
Yeah. Platelet has other issues if you use it for a long period of time, but for short periods of time, I think people consider that it's relatively safe. It shouldn't affect platelet function.
Some of the things you said to treat Paris-Trousseau, Demi's on tranexamic acid.
That's similar to Amicar, yeah.
That's okay then?
Yep. That's it. We're similar to Amicar. It works the same way. Once it stabilizes blood clots, so good after dental procedures. Things good for nosebleeds.
Same as Amicar.
Yeah, it's not this. It's similar, same type of medication as Amicar, so same function. Yeah. That was only recently approved in the United States. Previously, it was only available in Europe and Canada. So now it's available here.
And Tums was okay? Or was
Tums,
that
yeah, Tums should be.
because of
Nope.
calcium?
That should be fine.
The acid reflux is easy. You want to know what you can carry.
Yeah, well, that's actually important because for people that do have bleeding issues, if you have irritation in your stomach, then that could be a place that you can have bleeding. So it's important if you do have issues with ulcers or acid reflux that's under control, because it could be a site of bleeding. Other question?
Is there a recommendation for how often children with Paris-Trousseau should have the platelets checked?
So I typically check them most frequently in their first year of life, because that tends to be when they're the lowest. Once they've sort of improved into that more than 50,000 range, they tend to be fairly stable. They're not going up and down a lot. So I tend to check them most aggressively before a procedure. So if they're not having any bleeding symptoms, and they've already reached, they're more than a year old, and they've already reached probably as high as closer to as high as they're going to get. They're not going to go back down to 10 or 20 in most situations. So once they get to that more than 50,000 number and they're stable there, I tend to check them if they're having symptoms that are concerning me, or if they're going to have a procedure, and I want to know before the procedure for sure what their platelet count is. So if they're going to have a tooth pulled or go for a cath or something like that, that's when I'll check them. But otherwise, you don't need to usually check, weekly or monthly, or sometimes I check them once a year. Other than that, but that's about all.
So, is there something that would cause them to suddenly drop?
So typically, anybody can have their platelets drop below if they have a bad infection, a viral infection, if they develop an antibody against their platelets, if they're taking a medication that affects their platelet number. There are some medications that that have adverse effects on platelet numbers, so they can drop. But in the typical setting, usually once they've reached a certain number, they don't tend to go up and down a lot.
Limitations on physical activities? Is there anything?
Yeah, so that's always a hard question, because again, everybody is so different. Our typical restrictions for people when they have low platelet count is mostly on contact activities. So anything where there's direct tackling involved. For boys, that's most classically is football. Wrestling, where there's a lot of direct, hard contact. I tend to focus my limitations on the head. So for things like bicycling and skateboarding and whatnot, those are mostly dangerous if they fall and hit their head. So as long as they wear a helmet and things like that, I usually let people do those activities, just because if you start restricting everything, then you have no life. And again, and you have to be somewhat individual, because some people tend to bleed more than others, so you can't really make a blanket statement that all these people can't do these things. I let kids participate in gym class, because otherwise they're kind of too different at school. So again, most of the time gym class is pretty, most of the time they're not doing full-on contact sports in gym class, so I always have them go to gym class. Some sports that are really, if you do have concerns about bleeding, sports like track, sports like swimming, sports like, golf, those are all sports where really there shouldn't be much in the way of contact. Tennis, you should be able to participate without really a concern about bleeding. Soccer, I'm not a real fan of people hitting the ball with their heads, but otherwise I usually let them play, and that tends to be something that in the younger years it's usually they're just running around and they're not even kicking the ball that much. They're not getting that close to each other. As children get older, you may have to reassess, just because the leagues often become more competitive and there is more contact involved when they get older and more competitive. But in the younger ages, I usually let them do it. I think that there's so many downsides to not being physically active. You just don't want to be overly restrictive in terms of what they can and can't do. And bruising happens. I'm usually, if they get bruised, well, it's not a big deal. As long as their head's okay. Like the rest of it.
Thank you.
I have an online user that's asking, is there a correlation between the granular malformation and IGF-1 deficiency? She mentions her daughter has both and asks if one affects the other.
I'm not aware of any information. I do not believe so. IGF-1 is not really it's not really a component of the granules, so I don't believe that there is a relationship. I haven't run into that situation before, that question before, but I don't believe there would be a relationship.
Just wanted to clarify the recommendation for platelet transfusion for, I guess, major surgery, procedures high risk for bleeding, major trauma. Is that regardless of platelet number?
No, certainly not. I think if you have somebody who's got a good platelet count going into it, and they haven't demonstrated any problems with platelet dysfunction, you don't necessarily need to do those. You don't necessarily. You have to. There's some individual judgment that takes into place. I think you need to be prepared to do it. If you're going to have a surgery and you assess beforehand, like, well, my platelet count going into this is good, and I've had some challenges, and I've never really demonstrated a problem with the functionality of my platelets, then I'm going to go ahead and not plan to transfuse ahead of time. But I'm going to be prepared that if there's any unexpected bleeding, I will transfuse at that point. So I think you can do it. You can use your judgment to decide where you're going to place that. In the setting of trauma, you may not have that luxury to wait. So you might do something different in that setting because you really don't have time to really assess. And so in that setting, you may be quicker to give platelets if you're concerned about bleeding. But in the sense of a surgery, I think you can do a staged approach where you decide, I think I don't need them, but I'm going to have them ready just in case, and use them if I have to.
I have a question about using the information that you've provided with us. A lot of the kids are younger. My daughter's 23. I don't know how many of you guys have seizures, but my daughter started having seizures older, and because they were Jacksonian type, some of them we couldn't tell. Sometimes she'd have weakness on one side, and there was cause of concern of falls and traumas. So I had to talk to oncologists and everybody and get everybody together on it to help get a 1-to-1 aid so that someone's always within 3 feet. So if there is a fall, there will be any impact. Is there anything you can say in relation to everything that you're telling them to help them if they're having the same type of problem?
In terms of
not getting assistance in school?
In terms of not getting assistance?
How using the information that you provided, or maybe having, the protocol that Dr. Grossfield's had, so if ever anybody's having problems with their school districts on getting the extra help, or if your child does develop seizures, to make sure that someone is paying attention that they don't have a fall or an impact. Especially if you guys are around the 100 area like us, because you never really know if they're going to work.
Yeah, I mean, I think certainly schools, regardless of what your particular issue is, I think working with the school, your doctor in the school to help put in whatever safety precautions your child needs is important. And there's always going to be a lot of specificity for each person that way. We typically will send letters to the school, particularly regarding certain people saying, these are the things they can do, these are the things they can't do, these are the things that you need to call the parents about. And the social workers are generally very helpful in terms of also intervening with the school if there's problems instituting that, or if the school is not if the school's not being cooperative, which doesn't happen very often, but the social workers can help with that. The other people that are sometimes really helpful is sometimes our child life people actually go out to the school to help educate the children or the classroom, the teachers of the classroom, the other classrooms about the particular disorder that a child might be dealing with in a way that they can understand. So that can be somewhat helpful, but certainly that's something that you can work out with your school typically. But I think there's not a one size fits all type of solution. Yeah. Thank you.
We do now